1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's, charter book.
300 please.
I'll keep you on again.
Pulse check. No pulse.
No more pulse.
Yeah. Here, what do the ECMO people say? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Oh.
Picture this. A patient is sitting in your ICU bed. Their resting heart rate is, perfectly normal.
Right, and their EKG is completely quiet.
Exactly. I mean, they're chatting with their family, looking totally fine. But inside their left anterior descending artery, a microscopic structural flaw that started forming when they were 20 years old is about to crack open.
And in exactly 3 minutes, they will be in full cardiac arrest.
Welcome to the deep dive. Today, we are looking at coronary artery disease, or CAD, and we are moving way past the rote textbook memorization.
Because what's fascinating here is that we treat CAD in the public imagination like it's a sudden, violent event, a heart attack.
Like a lightning strike.
Right. But biologically, it isn't a sudden injury at all. It is a progressive, decades-long deterioration of perfusion, and perfusion depends entirely on one core mechanism.
Which is the heart's ability to generate enough cardiac output to actually distribute oxygenated blood to the tissues. Which is exactly our mission for you today. We are looking at this disease through the lens of an elite ICU intensivist and critical care nurse. We are aggressively applying the 80-20 rule to this source material.
Giving you the 20% of knowledge that yields 80% of your clinical understanding at the bedside.
Right. We're going to trace exactly how the physiology fails, how to spot the subtle exam traps that get people killed, and how to master clinical decision-making when the pressure is really on.
To do that, we have to trace the pathophysiology step by step. I mean, starting right at the cellular level. If you want to think like an intensivist, you can't just react to a patient grabbing their chest.
You have to understand the microscopic moment the physiology starts failing.
Yes. And that trigger is always endothelial injury.
The intima, which is the innermost layer of the arterial wall. Our sources describe it as being lined with endothelial cells that, in a healthy state, act like a non-stick Teflon coating.
That's a great way to picture it. Under normal circumstances, platelets, leukocytes, and, coagulation factors just glide right past it.
But if it's like Teflon, it shouldn't just degrade on its own. I mean, something has to be actively destroying it. I imagine the sheer physical pressure of hypertension is basically power washing that delicate layer away.
That is exactly the kind of hemodynamic stress we're talking about. The shearing force of chronic high blood pressure literally tears at those cells.
It's not just pressure.
No. You also have chemical toxins from tobacco use, hyperlipidemia, and systemic inflammation, all just battering that lining. Once that endothelium is injured, the physiological change begins.
The barrier is broken.
Right. The barrier is broken, and lipoproteins start transporting cholesterol directly into the damaged arterial wall.
And the timeline here is what usually shocks people. The sources note that by age 20, lipid-filled smooth muscle cells have already formed what's called a fatty streak.
It gives the inside of the artery this faint yellow tinge.
Yeah, so it's not something that waits for middle age. It's happening in your 20s.
Exactly. And from there, the body enters a compensation phase. It actually attempts to heal this damaged fatty area in the wall. Growth factors released by platelets stimulate smooth muscle proliferation.
So it's trying to patch the wall.
Right. Collagen moves in and covers the fatty streak. By the time a person hits 30, this has developed into a grayish, whitish, fibrous plaque.
Wow. By 30.
Yeah, and this plaque physically narrows the vessel lumen, severely altering the fluid dynamics of the blood flow to the distal tissue.
If we visualize this from like an engineering or fluid dynamics perspective, it's not just a pothole in a road, it's a high-pressure hydraulic line. The endothelial injury is a weak spot.
And the body tries to reinforce it.
Right, by packing it with whatever is lying around, lipids and collagen, creating this massive hardened internal speed bump. It narrows the pipe. But the real catastrophic threat isn't just the narrowing, is it?
No, it's the decompensation phase. As that fibrous plaque grows over the years, continued internal inflammation makes it highly unstable.
The protective cap thins out.
Precisely. The protective cap over the lipid core thins out. Eventually, the sheer stress from the flowing blood causes it to ulcerate and rupture,
The structural integrity fails. The hull is breached.
and the body panics.
Yeah.
It initiates a massive coagulation cascade. Platelets swarm the site of the rupture, but they don't just passively stick there.
They change shape, right?
Yeah, they physically change shape and activate, expressing these specific proteins called glycoprotein I-beta receptors on their surface.
And those receptors essentially act like grappling hooks. They grab onto fibrinogen that's circulating in the blood.
Which acts like cross-linking rebar.
Right. Tying all those individual platelets together into a massive, solid, concrete block.
And that concrete block is a thrombus. The process is aggressive platelet aggregation and adhesion. What was once just a fibrous plaque is now classified as a complicated lesion.
Which can partially or totally occlude the artery in, what, a matter of minutes?
Minutes, yes. This is the physiological reality behind the clinical findings we see at the bedside. Unstable angina, or a full-blown myocardial infarction.
Which forces a really important hemodynamic question. If this plaque buildup is slowly narrowing the pipe over decades, from age 20 to 30 and well beyond, how does the heart muscle survive?
Well, because it's gradual.
But why doesn't the tissue just slowly suffocate from the decreasing oxygen delivery for all those years?
Because the body is remarkably adaptive when given time. It utilizes collateral circulation. We have arterial anastomoses, which are essentially microscopic, built-in bypass connections within the coronary vascular bed.
Oh, like alternate routes.
Exactly. Their growth is driven by hypoxia-inducible factors. When tissue experiences chronic, slow ischemia, it releases chemical signals that promote angiogenesis.
The literal building of new blood vessels.
Yes, so the body senses the poor flow, realizes the main highway is getting backed up, and constructs a network of side streets to route blood around the blockage.
Okay, that is a crucial intensivist concept. Slow blockages give collateral circulation time to develop. So the myocardium might still receive an adequate amount of blood and oxygen when the patient is at rest.
Correct. At rest, they're often fine.
But let me challenge the efficiency of that system. If the body is so incredibly smart that it can literally build its own bypass network, why does a patient going for a light jog suddenly experience crushing chest pain?
Because of the physics of supply and demand.
And why do we see patients in the ICU crashing so quickly if they have these side streets built in?
Well, those tiny collateral vessels have severe physical limitations. At rest, they provide just enough flow. But the moment you increase the cardiac workload, like during exercise, extreme stress, or, say, fighting an infection in the ICU, the myocardium's demand for oxygen skyrockets.
And the side streets can't handle the traffic.
Exactly. Those small side streets simply cannot accommodate the massive volume of blood needed at that exact moment. You hit a rigid hemodynamic bottleneck.
Ah, so the flow reaches an absolute physical ceiling.
Right. And the exam trap for a critical care nurse here is differentiating between a chronic blockage and an acute one.
How so?
If there is an acute coronary occlusion, say a sudden plaque rupture and massive thrombus, or a severe coronary spasm, the collateral circulation does not have time to develop.
Because it happens in minutes, not years.
Exactly. The tissue is abruptly cut off from its oxygen supply. This results in severe, rapid ischemia and tissue infarction.
So understanding that deterioration cascade means we have to recognize the combustible mix of risk factors that accelerate the exact plaque rupture we just laid out.
We hear about high cholesterol and blood pressure constantly, but we need to look at them through the lens of failing physiology.
Right, like what is actually happening at the cellular level when a patient's lipid panel comes back flagged in red?
We have to look at the transport vehicles. A total cholesterol over 200 milligrams per deciliter or triglycerides at 150 or higher, those are major red flags.
But the real story is in the lipoproteins, right?
Yes. You have LDLs, the low-density lipoproteins, and HDLs, the high-density lipoproteins. LDLs contain a massive amount of cholesterol and have an active chemical affinity for arterial walls.
So an LDL over 130 means you basically have a fleet of dump trucks actively depositing cholesterol right into the endothelium.
That's a perfect analogy. But HDLs do the exact opposite through a mechanism called reverse cholesterol transport. They are the cleanup crew.
They actively bind to lipids in the arterial wall, pull them out, and carry them back to the liver to be metabolized and excreted.
Exactly. That's why keeping HDL above 40 in men and above 50 in women is a measurable goal. You need enough cleanup crew to outpace the dump trucks.
Then you add hypertension into that turbulent environment. A blood pressure consistently over 120 over 80, creates that profound shearing stress we discuss.
And hemodynamically, narrowed arterial walls also dramatically increase the systemic vascular resistance, or SVR.
The heart is forced to pump against a much higher afterload.
Right. This chronic overworking leads to left ventricular hypertrophy. The muscle wall gets thicker and stiffer, which actually decreases stroke volume and cardiac output over time.
Here's where it gets really interesting, though. If you want the ultimate textbook example of a supply and demand disaster, look at tobacco use.
Oh, absolutely. It's a physiological double whammy that attacks both sides of the equation simultaneously.
First, the nicotine hits the system and triggers a massive release of catecholamines, specifically epinephrine and norepinephrine.
And those catecholamines bind to alpha-1 and beta-1 receptors. The alpha-1 receptors cause peripheral vasoconstriction, clamping down the blood vessels and driving up blood pressure.
And the beta-1 receptors spike the heart rate.
Exactly.
Right.
So the heart's workload and its demand for oxygen just shot through the roof.
But at the exact same time, the carbon monoxide from the inhaled smoke enters the bloodstream. And carbon monoxide has an affinity for hemoglobin that is, over 200 times stronger than oxygen?
Over 200 times, yes. It literally kicks the oxygen right off the hemoglobin bus and takes its seat.
That is wild. So the myocardium is desperately crying out for more oxygen because of the nicotine-induced tachycardia. But the carbon monoxide is ensuring significantly less oxygen is actually being delivered.
And to make matters worse, carbon monoxide is a direct endothelial toxin.
It physically damages that Teflon lining.
Yes, feeding right back into the plaque building cycle. It is the perfect storm for cardiac tissue starvation.
The source material also mentions specialized diagnostics for intermediate or high-risk patients, things like C-reactive protein, or CRP, which is a systemic inflammation marker produced by the liver.
There's also homocysteine, an amino acid breakdown product, and lipoprotein.
When elevated, these directly promote plaque buildup and alter the clotting cascade. But the clinical pearl here is that these are not for routine screening, right?
Right. They're targeted tests used only when you already have a high index of suspicion based on the patient's presentation.
Which brings us to the most vital part of the critical care mindset: clinical pattern recognition.
Because we know the molecular mechanisms, but the clinical presentation frequently fools novice clinicians.
And the consequences are deadly, especially when dealing with vulnerable populations. I think this might be the biggest exam trap and real-world pitfall we covered today: women and heart disease.
The statistics are jarring. Heart disease kills almost 10 times more women than breast cancer. It is the undisputed leading cause of death in women.
Yet it is chronically missed at triage.
It is missed because the presentation does not fit the traditional textbook model.
Women tend to develop CAD about 10 years later than men, partly due to the cardioprotective effects of natural estrogen before menopause, which helps maintain endothelial flexibility and healthier lipid profiles.
But the crucial assessment trap for a bedside nurse is the symptom profile. Women frequently do not present with that classic crushing elephant on the chest pain radiating down the left arm.
The sources explicitly highlight that profound, unexplained fatigue is often the first symptom of acute coronary syndrome in women.
Fatigue, exactly. They present with shortness of breath, vague upper back pain, indigestion, or sudden anxiety.
And because these symptoms are atypical, they're often misdiagnosed as panic attacks, GERD, or musculoskeletal strain.
Which leads to devastating delays in women seeking treatment and in healthcare providers actually initiating the ACS protocol.
Consequently, women have a higher mortality rate after their first myocardial infarction than men, and they suffer higher complication rates post-TBOE surgery.
To be an elite provider, you have to completely discard the idea that an MI only looks one specific way.
We see that same need for heightened vigilance with our diabetic patients. The incidence of CAD is 2 to 4 times greater in people with diabetes, even if their blood glucose is relatively well controlled.
And instead of just saying diabetes accelerates it, we need to look at what excess glucose actually does. It's not just floating innocuously in the plasma.
It binds to proteins in a process called glycation,
creating advanced glycation end products, or AGs.
And our sources say these compounds act literally like microscopic shards of glass, constantly tearing at the endothelial lining.
Yes. This endothelial dysfunction, combined with profound changes in lipid metabolism, causes accelerated diffuse plaque development. But the truly dangerous part is the diabetic neuropathy.
Right. The autonomic neuropathy damages the nerve that would normally transmit the afferent pain signals from the starving heart muscle to the brain.
Which results in silent MIs.
The patient is actively infarcting tissue but feels absolutely no chest pain.
That is why strict glycemic control, aiming for a hemoglobin A1C of less than 7%, is a non-negotiable priority in their care plan. It is a direct intervention to preserve the endothelium.
We also have to look at the genetic blueprint. What if a patient does everything right, perfect diet, no smoking, and still ends up with a massive fibrous plaque?
That's where familial hypercholesterolemia comes in. It's an autosomal dominant disorder.
Heterozygotes appear in about 1 in 500 people, but homozygotes are rare and incredibly severe, with cholesterol levels easily exceeding 600 milligrams per deciliter.
Their LDL receptors on the liver are genetically defective. The vacuum cleaners that are supposed to pull LDL out of the blood simply don't work.
For these patients, you assess for xanthomas, which are, visible fatty growths on the skin, often around the eyes or over joints.
Because this is a genetic receptor failure, standard diet and exercise modifications are entirely insufficient. Their treatment relies on specific lipid-lowering therapies, particularly PCSK9 inhibitors.
And how do those work physiologically?
PCSK9 is a protein that normally destroys LDL receptors on the liver. By administering an inhibitor, we block that destruction.
So the liver retains more receptors.
Exactly, which means it can pull far more LDL out of the bloodstream, dramatically lowering the serum cholesterol levels.
Now let's talk about differentials, because this is where an intensivist really proves their worth. What presents exactly like CAD, with severe chest pain and ischemic EKG changes, but has a completely different underlying trigger?
Illicit substance use, specifically profound stimulants like cocaine or methamphetamine.
This is a massive ICU pearl.
To the nurse at the bedside, it looks identical to acute coronary syndrome. The patient has extreme sinus tachycardia, dangerous hypertension, and crushing chest pain.
But the underlying pathophysiology isn't a ruptured fibrous plaque.
No, the massive sympathetic surge from the stimulant causes profound coronary artery vasospasm. The vessels forcefully clamp down.
So the tissue is starving and ischemic, but it's a sudden chemically induced spasm combined with an astronomical oxygen demand.
Your priority nursing action here is rapid differentiation. You need a prompt 12-lead ECG, cardiac biomarker draws, and a comprehensive toxicology screen.
You must definitively figure out if you're dealing with a complicated atherosclerotic lesion that might need a cath lab or a substance-induced spasm.
Because the pharmacological management branches significantly from there.
Okay, we've unpacked the cellular level, the hemodynamics, and the vulnerable populations. Let's bring this all directly to the bedside to synthesize our plan. How do we know a CAD patient is actively deteriorating right in front of us?
You are watching for the compensatory mechanisms to fail.
What are the vital trends?
The patient is getting worse if their cardiac workload increases. Say they develop a fever, become highly agitated, or physically exert themselves, and there is no compensatory increase in oxygen delivery.
You will see the heart rate climbing as it desperately tries to increase cardiac output.
And the mean arterial pressure, or MAP, might initially spike from pain and sympathetic drive. But as the myocardium starves and the pump begins to fail, that MAP will start to drop.
You'll see the urine output fall as the kidneys get hypoperfused.
Yeah.
You'll see their mentation change, becoming restless or confused as cerebral perfusion drops.
If you run an ABG or check a lactate, you'll see rising lactic acid as the starving tissue shifts from aerobic to anaerobic metabolism.
If they develop unstable angina at rest, that means the myocardial oxygen demand has fundamentally outstripped the supply, and that unstable plaque is dangerously close to full occlusion.
When you step back and look at the patient, the clinical reasoning always comes back to that core cascade.
If we were to paint a one-sentence clinical picture of this disease, it would be this. A middle-aged patient presenting with a long history of endothelial stress, from hypertension, tobacco, or diabetes, whose compensatory collateral circulation has hit its physical bottleneck and can no longer meet the myocardial oxygen demand, resulting in active tissue ischemia.
That perfectly summarizes the 80-20 breakdown.
Let's lock this in with the actions that change outcomes, the 5 things you must remember. 1. If you miss the atypical symptoms in women, like profound fatigue or back pain, you give that unstable plaque time to rupture and form a complicated lesion.
2. You miss the window for early intervention. If a diabetic patient presents with vague nausea and shortness of breath, your mind must immediately consider a silent MI due to their neuropathy.
3. The most dangerous complication is plaque rupture, causing a thrombus that totally occludes the vessel without time for collateral circulation to compensate.
4. Your most important long-term treatment strategy is always aggressive risk modification to protect whatever endothelium they have left.
That means heavily lowering LDL cholesterol, utilizing active smoking cessation interventions like bupropion or varenicline, and maintaining strict, measurable blood pressure and glucose control.
And 5, for that critical pattern recognition. If you see a young patient with unexplained severe chest pain, extreme sinus tachycardia, and sky-high blood pressure, think substance-induced coronary spasm.
Your immediate action is a prompt ECG, cardiac biomarkers, and a toxicology screen to rule out stimulants before you treat it as standard atherosclerotic CAD.
If we connect this to the bigger picture, though, there's a looming unknown that we have to discuss.
Oh, absolutely.
We understand the precise endothelial damage that combustible tobacco causes, but right now we are seeing a massive, rapid rise in the use of high-concentration electronic cigarettes.
Which our sources explicitly note still carry cardiovascular and endothelial risks that we simply do not fully understand yet over the long term.
So here's a final thought for you to mull over. With this entirely new wave of vascular exposure hitting the population, are our current 10-year risk calculators completely underestimating the impending wave of early-onset CAD?
Because vaping lacks the carbon monoxide, people assume it's safe.
But the massive nicotine load is still driving that relentless catecholamine surge and sheer stress. Are we going to see complex fibrous plaques rupturing a full decade earlier than our current models predict?
It's a chilling thought for the future of critical care. We really are looking at a disease that is decades in the making. It's not a sudden light switch flipping off in the emergency room.
It's a slow, invisible rust inside the pipes.
And we have to be smart enough and vigilant enough to catch it before the system breaks. Keep questioning the physiology, keep looking beyond the textbook presentations, and keep trusting your assessments. We'll see you in the next deep dive.